Today, I'm going to be doing a deep dive with Dr. Elias Abi Khalil on fibroids. Dr. Elias is an OBGYN who's been in the field for over 10 years, and he currently works at CMC Hospital in Dubai. His specialty is in helping women manage their pelvic pain. What I love most about this conversation is that he understands that just because menstrual pains are common does not mean it's normal. Today, we're really going to be doing a deep dive on fibroids. We're going to talk about how to diagnose them, what treatment options look like, and what the implications could be for pregnancy. This is going to be a very informative conversation. I really hope you enjoy it. Please share it with people that you think could benefit and share it with the women in your life. Dr. Elias, thank you so much for being here with me today. I know you're a very busy doctor, so we all appreciate your time being on the show with me to share all this information around fibroids. It's such an important conversation, so I'm very grateful to have you here. How are you today?
I am good. Thank you for having me here. It's such a pleasure and honor to be with you on this podcast and sharing some information about, women's health and especially pelvic pain and fibroids.
Before we get into all the questions I have for you around fibroids, I'd love to ask you first a little bit about your journey and why you chose this expertise and how you got here.
So I started this journey by, first falling in love with women's healthcare when I was back in medical school, and I decided to be an obstetrician gynecologist. And then through my residency in the US, I decided that I want to go into the field of minimally invasive surgery and in the field of endometriosis and fibroids. And the decision based on that is related to the most common complaint that we get in gynecology, which is pelvic pain. And I know that pelvic pain is undermined in our part of the world. People are not taken seriously, and most of the women are dismissed with their pelvic pain only because pelvic pain is a is a widespread topic, and it's time consuming to go into details of the pelvic pain and trying to figure out exactly what is the reason for that, and that most physicians are busy and they don't have the time to go into the details, and that's why most women are dismissed with their symptom and they end up with years of pain. So basically, the main reason is women with pelvic pain are most commonly dismissed with their symptom because it is time-consuming to go into details of what's going on and find out the real reason why they are in pain. And they will go years and years without someone really diagnosing them with the reason why they have pain, and they go into a long-term struggle. So that is one of the initiatives why I really like what I'm specialized in.
It sounds like you recognized and identified a demand in the field, and you decided to specialize in it because there is always a reason for pain, it sounds like. And, as women, we are taught that being a woman just means we have pelvic pain and it's common and therefore it's being normalized. And now we're starting to learn, and doctors are starting to become more aware that just because something is common doesn't mean it's normal. And maybe a little bit of tenderness is okay, but the amount of pelvic pain that I've come across in my life with clients and with friends, they can't function once a month, and that's absolutely not normal. And we really appreciate, the knowledge and the doctors that are now taking this on board as something serious, because I think women in healthcare are gaslit when it comes to pelvic pain, and it sounds like that's something you recognize. So it's very appreciated. Let's start with just understanding what a fibroid is.
A fibroid is a benign growth inside the wall of the uterus. It starts with one cell having some mutation, and this cell replicates identical cells, and they cause benign, small tumors inside the uterus that can grow to larger sizes.
How does someone develop a fibroid? Where does it come from?
The real reason for initiation of fibroid formation, we really still don't know. We know that there are mutations that happen or inherited mutation that can cause these cells to transform and to replicate and form these benign tumors. Now, there are several risk factors for people to develop fibroids, and these are the ones that we rely on usually in our evaluation.
Such as?
So, the most important factor is genetics. Some people are predisposed to developing fibroids, and we also know that race and ethnicity is a very important factor. For example, African American people have a higher tendency to develop fibroids. Also, the other risk factors are related to the long-term exposure to estrogen. For example, early menarche, less than 10 years of age, that puts you more into exposure to estrogen, obesity, because of the peripheral conversion and production of estrogen. Diet is also related. People who consume red meat or beef also are at increased risk. People who consume leafy vegetables or fruit, it appears to decrease the risk. Omega-3 pollutants can increase the risk, vitamin D deficiency, alcohol, surprisingly, and especially beer appears to increase the risk. And of course, like anything in life, chronic stress and anxiety can predispose you to develop fibroids. A lot of people ask this question, if I take the pill or hormonal contraception, does that increase my risk of developing fibroids? Well, surprisingly, combined oral contraceptions have still not yet been related to, to cause growth of the fibroids. But we don't know if they're related to initiation of the formation of fibroids. There are other risk factors that would decrease the risk, like if someone has multiple pregnancies during their lifetime because they're interrupting the cycle of continuous estrogen exposure. Dairy products would decrease the risk, vitamin A, and also studies have shown that if you have long-acting contraceptive devices like a Mirena IUD that you get, continuous progesterone exposure from, can, halt a little bit the growth of fibroids.
You said something about omega-3, and then there was another word after it, something I didn't recognize, and you said that that could increase your risk. What is that?
It's omega-3 pollutants, marine pollutants that you can find. It's stuff that you find in, when you eat fish, basically products from the sea.
We are taught that omega-3 is anti-inflammatory, and it's actually really healthy for you, and we need to balance our omega-3 and omega-6 ratio. And so you're now saying that omega-3 can actually increase your risk of fibroids.
So omega-3 pollutants decreases the level of omega-3. Do you understand?
Got it.
Okay. So it's basically having an omega-3 deficiency from pollutants will cause you this.
Okay. I'm glad we cleared that up. You mentioned obesity, diet, lifestyle, and I'm sure ultra-processed foods and sugars will also impact or implicate someone's risk for developing fibroids and potentially being estrogen dominant. Would you agree?
Yeah.
How do we diagnose a fibroid?
So fibroids are first diagnosed by, history. Okay, so basically listening to the patient, if they have any symptoms, they usually present with the symptoms of heavy periods or pelvic pain. And the diagnosis, the easiest diagnosis is by an ultrasound in the clinic that will allow us to identify fibroids very accurately and identify where they are in the uterus and how big they are.
What are other symptoms of fibroids? Is it just pelvic pain and heavy periods, or are there other things that women can look out for?
Yeah, the main symptom is heavy or abnormal periods, okay? And that will depend on where the fibroid is in the wall of the uterus. The other common symptom is bulk symptoms. Bulk symptoms mean when you have multiple fibroids and they are large enough to cause pressure symptoms in the pelvis, pressure on the bladder or pressure on the colon or the rectum, and space occupying pressure, because the pelvis is a small, is a small volume or small area. And then if you have a growth of the uterus inside the pelvis, it will occupy most of the space. Some other people have intercourse pain, or what we call dyspareunia. And then because the uterus sits on top of the vagina, and then when the uterus is enlarged, you can have the touching these fibroids, and the movement of the uterus will cause pain during intercourse. Some people will have urinary feeling of they want to pee all the time, and this is what we call an overactive bladder. And that's also because the uterus and the fibroids sit on the dome of the bladder, and it does not let it fill up completely to its normal capacity. So people feel they want to use the bathroom all the time. If you have large, very large fibroid, they can impinge on the rectum and cause rectal pressure or, constipation. But that's if the fibroids are pretty large.
Would you recommend that young women look out for this or get tested for this? Or do you think that they should just come into clinic when they have serious symptoms? Like, is this something, when women get into menopause, we're told that we need to check our breasts to make sure that we're not developing breast cancer later on in life. And we're being advised to do mammograms later in life. Would you say that this is similar in the sense that a young teen or someone in their early 20s should be regularly checking for fibroids so it doesn't get to the bulk amount, or it doesn't get not dangerous, but potentially really impactful, where it can cause constipation or problems or potentially fertility issues?
Most of the, I mean, most of women should have their regular annual checkup every year, starting 21 years of age. And part of the checkup is doing ultrasound of the uterus. And usually, when we discover fibroid, we tend to keep watching them for growth and for symptoms. And of course, physicians should relay the message that you have a fibroid, and explain what that is, and lay out a plan on how frequently they should follow that, and make sure they don't grow to sizes where they start causing problems.
How do fibroids impact a woman's life outside of having symptoms that are uncomfortable? And can it potentially impact their fertility?
Um, of course, fibroids are one of the main reasons for infertility, and it can definitely impact spontaneous pregnancy rate, but also it can impact IVF outcomes. And the reason behind that is um, fibroids can exert pressure on the cavity itself of the uterus, okay, and prevent implantation. They can also distort the cavity in a way that the embryo is not able to implant. The other reason is the mere fact they are present in the uterus itself can alter the blood flow of the uterus, and also prevent implantation. Some fibroids also block the cervical canal, which is the lower part of the uterus, and prevent, the normal flow of sperm into the uterus to meet the egg. Some fibroids also impinge on the tubes, so it depends on their location. But fibroids are one of the main reasons for infertility.
You specialize in fibroid and endometriosis, and I know that both of these conditions cause pelvic pain. So it makes sense that if you're interested in female pelvic pain, that you're specialized in both. But is there a connection between fibroid growth and endometriosis growth?
Yeah, this is my favorite question, by the way, and I think um, it, this is what most, I would say, physician miss when they are treating somebody with fibroids or treating somebody with endometriosis. These entities cannot be treated separately. You can't be just specialized in fibroids and not deal with endometriosis and vice versa. And for many reasons. The first reason is just based on studies. We know that 20% of women with symptomatic fibroids, okay, if we go inside and look inside the belly or in the pelvis, okay, we will find endometriosis too in 20% of cases. That's 1/5 of women. And of those patients, up to 50% can have adenomyosis, which is endometriosis of the uterine muscle. So the idea of just treating fibroids is doomed to just fail. Okay, fail because our main goal here is not to just treat fibroids and prove to the patient that we have removed their fibroids. The idea is to really help them with their symptoms and with their fertility part. So we have to treat these three conditions, fibroids, endometriosis, and adenomyosis, as a triad. And the triad means that anytime we are looking at fibroids, we have to have in the back of our mind that this patient might have endometriosis or adenomyosis. Vice versa, if she has endometriosis, I always look for fibroids. If we have adeno, I always look for fibroids or endometriosis. Some people don't understand that they're diagnosed with adenomyosis, and physicians just, tell them that the treatment is just to remove the uterus itself. And that's not the treatment for that, okay? Because we know that adenomyosis is also a form of endometriosis. So if you have adeno just apparent on an MRI and they can't see endometriosis, the most likely scenario, you're going to go in to remove the uterus and you're going to encounter endometriosis. So you got to treat both together, okay? So having an expertise in all three is an essential part of really taking care of these conditions. And these three conditions, they share common symptoms. So a patient presenting with pelvic pain and having few fibroids, okay, you should always be skeptical about, well, maybe she also has endometriosis, okay? And if you really listen to her symptoms and dissect a little bit the type of pain she is having and how this pain is happening, then you can really know what is behind this pain. Okay, with time you'll get to know this pain is related to endo, or this pain is related to adeno, or this pain is related to fibroids. They have some nuances between them, but in general, the triad is very important. This is if you want to be the most important message for people who have fibroids or who have endo or adeno, is do not let somebody treat you just for one of these conditions. These three should be treated together if you want to, first, feel better, second, improve your fertility. So for example, when I'm operating on someone who has fibroids, in the consent form, we always write possible excision of endometriosis, because, they present to us with pelvic pain or heavy bleeding. We do an MRI. The MRI shows multiple fibroids. It can obscure sometimes, endometriosis, or MRIs, they're not perfect for endometriosis detection, especially if you have early stage endometriosis. But in the back of our mind, that 20% will have endo. And if the symptoms, we feel that these symptoms are more likely to be endo than fibroids, then we can send the patient for also removal of endometriosis. And that being said, this is an extra effort from physicians and extra risk, because we know that fibroid surgery is something and endometriosis surgery is something else. Combining both really needs the first be able to do both, having the training to do both, and have, a little bit more ethics into treating somebody. Um, because it's easier for me to just go in and just remove the fibroid and leave the endo behind. It takes me less time, and um, so that's why in our practice we don't really look at um, just what we see in the MRI. In my practice, we treat the three together, and that's why people listen. Pelvic pain does not lie. Okay, so if you have someone and you have not treated them the right way, 3 months later they will come back with pelvic pain. There is no hiding that. I mean, even if patients don't know, their symptoms will tell them. So I see a lot of patients for, failed surgeries 3 months after, or 4 or 6 months after the surgeries. And I mean, the first thing I say, I need to see the video of your surgery, because have they missed endometriosis while removing your fibroids? Or have they missed, rectovaginal endometriosis while they're removing your endometrioma? That's also a big, huge mistake that most gynecologists do. You have endometriosis, you have it on the ovary, that's what it shows on the MRI, but then you don't have it, it doesn't show on the MRI that you have it, deep in the pelvis. So they go in, they remove the cyst, and they leave half of the endo. That's not gonna lie, patients will come back with pain. So it's very important, because patients will know eventually that they didn't have the proper care.
So, ladies, this is such an important note. And I've also heard that sometimes fibroids are asymptomatic. They don't really give you symptoms, and the pain is actually coming from endo, but it's not being shown in the MRI or the scan, and you think that your pain is from fibroids. So, I think this is such an important note to drive home, that when you are looking for a doctor and you're potentially looking for surgery, you want a doctor who specializes in all three. And then if you are going into surgery, that they are capable of excising or managing or dealing with any of those three. Why do you think those three are connected? Is there a medical reason why a woman would have endo, ado, and also have fibroids? Is there a reason that we develop those things in the body? Is it the same kind of hormonal issue, or is it an ethnicity issue, obesity issue, a genetic issue that contribute to all three?
Well, we know that they're all related to inflammatory markers in the pelvis. And also, the common thing between them is they're all responsive to estrogen. So, but we don't know exactly the details of what's going on. But we know that they have common, etiologies. We know that there is inflammatory marker that causes chronic inflammation that is fueling both endometriosis and fibroids. There are also genetic factors that are involved in both conditions. And of course, this symptomatology of both conditions, the pelvic pain or the heavy bleeding, they both can cause the same thing. So we know that there is some connection there, but we're not 100% sure what it is.
I went to a talk recently with Barbara O'Neill, and she was talking about how estrogen is a cell proliferator, which means that if you have too much estrogen in the body, the liver is not being able to detoxify it properly. That estrogen proliferates cells and causes types of growths or tumors. And so that's important to understand when it comes to growths like fibroids, tumors, endo. And so really having a diet and lifestyle, obviously we can't control our genetics, although they say, genes or your DNA will load the gun, but lifestyle and diet will pull the trigger. So just because your family has a genetic predisposition to a disease doesn't mean you need to display it. But there are some genetics that I don't think we can get away from, but it's a very small amount apparently. But if we take into consideration our diet and lifestyle and we are eating properly and managing our stress, then our liver can eventually detox the excess estrogen, and then we're less prone to developing these growths. That is not just about the pelvic growths, it's also apparently like growths in the breasts. So I hear estrogen is such an important hormone to, well, in the ratio with progesterone, it's such an important balance in a woman's body. Otherwise, we start to see these growths. I'd love to ask you some treatment options and surgery options for women who are struggling with fibroids. What does it look like for them, and what's some advice you could give to them before they get into surgery or when they're looking for their doctor?
The first advice I give to them is not everybody with fibroids and endometriosis need treatment. So many people just don't need treatment, they need surveillance, whether it's endometriosis or whether it is fibroids. Let's focus more on fibroids today, but most of my patients with fibroids, they're not on treatment. Whether it is medical treatment or surgical treatment, because most of these women are asymptomatic. Okay, so to really need treatment for fibroids, you need to have symptoms. Okay, and symptoms are related to where the fibroid is in the uterus, how close to the cavity it is, and how big they are and how many they are. Okay, and most of fibroids discovered don't meet any criteria for treatment. Now, for patients who are symptomatic or having symptomatic fibroids, this is where treatment is recommended, and that will depend on what is the symptom or what is the basically chief complaint. What are they coming to you for? So the major symptom is heavy period leading to iron deficiency, anemia, okay? And then it becomes chronic anemia because of the continuous bleeding every month, okay? People needing multiple iron infusion or multiple admission to the hospital for this symptom. These people need treatment. Okay, now it depends on how old they are also, what's their fertility or their parity, basically if they have kids or they don't have kids, and how close they are to menopause. Usually the first line treatment for fibroids causing heavy period is medical therapy with progesterone to try and decrease the amount of bleeding that they have and control a little bit the blood loss that happens every month. When medical therapy fails, then surgical therapy is pretty effective in fibroid surgery, in fibroid treatment. Usually, for medical therapy, you have oral therapies, you have long-term therapies like Mirena IUDs, you have an Implanon, which is the small device that goes inside the arm. Also, they're all based on continuous progesterone secretion. And the important thing to know in medical therapy is we are not treating your fibroid. It's not going to disappear with progesterone. The fibroid will stay there, but we're trying to control the symptoms. Okay, that's why with heavy bleeding, we can use medical therapy. But for some reason, somebody coming with huge fibroids causing bulk symptoms and pelvic pain and intercourse pain, that's not going to be treated with medical therapy. You need to make these fibers disappear.
So the medical therapy is to administer progesterone to again help that estrogen dominance balance. And does that just manage the symptoms, but does it also manage the growth of the fibroid so it stops growing, but it doesn't heal the fibroid, but it stops the growth?
Well, the results on those studies is conflicting. We don't have real proofs that if you take progesterone for a long time, your growth will stop the growth of the fibroid. Okay, That's why we don't use it in clinical practice. In clinical practice, if someone asks me, I'm taking this medication, is it going to resolve my fibroid? The answer is no. It is going to control your symptom. Okay. Now, also, as I told you, Alia, the importance of the position of the fibroid is more important than sometimes the size. You could have a 5 centimeter or 6 centimeter fibroid sitting outside the cavity, okay, asymptomatic, not causing any problem. You could have a 2 centimeter fibroid sitting inside the cavity, causing severe hemorrhage every month. So really, the size, of course, when I say size, we're saying, you know, small sizes, less than 10 centimeter fibroids. Okay. When it gets to larger sizes, I mean, the fibroid becomes larger than the uterus itself, and it just causes symptoms, you know, independent of where the location is. But we're talking about fibroids that are more or less than 10 centimeter. Yeah, the location is more important than the size. So the goal is not to shrink the fibroid. The goal is to control the symptom.
Can you walk us through some of these medical interventions? Because I've never really heard about the one that's in the arm. And what are the side effects of taking progesterone like that?
Progesterone comes in different forms, and we have the oral forms. They are pills that you take every day. You don't stop to have a period, and these will hopefully stop your period in a way that you don't bleed every month, so you don't have anemia anymore. Same, people have come up with other devices that can secrete progesterone on a daily basis. And you have the Nexplanon, which is a small insert, okay, that goes inside the inner part of the arm here, okay, and it secretes progesterone on a daily basis. You have the Mirena IUD, of course, if you don't have a large fibroid sitting in the cavity, so that you can place the Mirena, because sometimes when you have large fibroids in the cavity, causing pressure on the cavity, the Mirena can be expulsed, so it won't last there. But the main idea is progesterone every day to try and minimize the amount of bleeding that is happening. I mean, the side effects would be the same as the birth control pill, but mostly the most common side effect of the progesterone only is unscheduled bleeding. So people can have spotting every day, and that's what annoys them the most.
But taking away a woman's cycle, a woman's monthly cycle and the bleed, I mean, the birth control pill doesn't take away the bleeding, it takes away your ovulation. But this progesterone seems to be taking away the bleeding completely. So a woman can go months, if not years, without bleeding. Wouldn't we argue that we're kind of interfering with the body's natural system and cycles and that there's potential dangerous side effects to that?
I mean, the only potential really concerning side effect is if you take progesterone for a long time, then it could affect the bone density. But we're talking about years of progesterone, sorry. Mirena IUDs are not linked to decrease in bone density. Mostly oral progesterone is linked to that. Now, not having a period every month is only going to cause PMS symptoms, but health-wise, it won't affect anything. It won't affect your fertility, because once you retrieve those progesterone from your body, your cycle will resume normally. So now we've talked about if you have heavy periods and the medical treatment for it. As I mentioned before, when it comes to bulk symptom, pressure symptom in the pelvis, unfortunately, the only really effective way is to do surgery. Or if we're talking about infertility related to fibroids, also the most effective way is surgery. Now, some people ask me a lot about uterine artery embolization, which is basically closing the main vessels that feed the uterus in order to be able to shrink the fibroids and relieve a little bit the bulk symptom. For me, I don't really like this method much because first you are closing the supply to the whole uterus. So you're killing the fibroid, but you're killing also, you know, muscle cells, normal muscle cells. That's for one. For two, um, uterine artery embolization can also affect the main vessels that go to the ovaries. So can also affect the ovarian reserve. And, there are cases of people having, you know, menopausal symptoms after that. The third reason is sometimes when you have a large fibroid, and it's touching the cavity or it's inside the cavity, and if you do a uterine artery embolization, you're basically killing those tissues. And when you kill those tissues, sometimes you get a chronic discharge that is really foul smelling, and this will get people to end up with a hysterectomy after that to relieve them from this symptom. So that's why I don't feel that this is the ideal way of going. I feel that nowadays, with our advancement in surgical procedures, that would be the better option.
And so, if a woman does decide to go the surgery route, what is the likelihood of her fibroids returning? And what does the recovery look like as well?
The recurrence rate of fibroids can go up to 40 or 50% in the next 5 to 10 years. And the recurrence rate depends mostly on, did we remove all the fibroids that we could see on the MRI? Okay? Because nowadays we're doing minimally invasive surgery. We're not doing open surgery for fibroids. So you lose this tactile feeling of feeling where the fibroids are and removing them. Okay? It all goes down on your 3D imagination of the MRI images and knowing where exactly this fibroid is, especially if they are small. So what happens during surgery is we're doing minimally invasive surgery. It means a camera and two ports and to try and remove the fibroids. Mostly the big ones are going to appear, even if they're inside the wall, they're going to appear to the outside of the uterus, and these are easy to remove or to identify. But you are left behind with small fibers that are inside the wall that you cannot see them from the outside. You're going to have to resort to the MRI to be able to find their location and imagine where they are in a 3D visual and go get them. Okay? Now, the biggest mistake that people do is, I have a lot of patients that go to fibroid surgery without an MRI. So I don't understand how their surgery is done. They're probably having the ones that appear on the ultrasound removed because they can see them from the outside, but they are small ones, they are not removed. And when you don't do that, that increases your recurrence rate because that small fibroid is going to grow 1 to 2 centimeters per year. And 2, 3 years down the line, it's a fibroid that is starting to cause problems. So, in my opinion, the most common reason for a high recurrence rate is the incomplete removal of fibroids. Now, also, you want to balance between being aggressive on removing all the fibroids versus leaving the small ones that need more dissection in the wall of the uterus. And it's all going to depend on the patient and what we're looking for, the symptomatology. Okay? So it will majorly depend on the age of the patient. So you really have to treat every patient on their own. You can't just generalize. Sometimes you are more aggressive on the fibroids to remove them all. Sometimes you're less aggressive just to serve a purpose, like let's say fertility, and not to injure too much the wall of the uterus so that they don't have a risk of uterine rupture during pregnancy. So it's going to depend on your patient and your counseling to her and eventually agreeing on a plan.
So you're saying that a lot of the recurrence rate is actually from an incomplete surgery or from a lack of um, recognizing that there were fibroids there that a doctor maybe missed or didn't see, or they were too small to capture in imaging. But let's say there's one big fibroid, 10 or 12 centimeter. I think you said if it's above 10, you would categorize it as being larger. What's the recurrence rate of like that fibroid coming back? Not fibroids that maybe we didn't catch, but There was one that's very obvious. We went in for surgery just to remove that one. Is there a recurrence rate in 5 to 10 years of that one coming back? And do you think women who have surgery in their 30s, so they're not yet close to menopause, so we're not talking later in life, do you think that they need to have multiple surgeries before they hit menopause?
Yeah, that's a very good question. Um, Removing one, let's say you have a patient with one big fibroid and you remove that, okay? Now the recurrence rate is going to be independent of that fibroid because we know that she has a risk factor to developing fibroids. So she might have other fibroids developing in the uterus. It doesn't necessarily mean this fibroid will grow again because when we remove this fibroid, that fibroid is gone. So other fibroids will develop. Okay, now studies are not really clear on incomplete versus complete surgeries or one fibroids versus multiple fibroids. So, but that's why the range of recurrence is high. We're talking about 10 to 60%. Okay, and that will depend on what people have done and how good the preoperative evaluation is and how complete the surgery was, you know. So if someone is coming with a large fibroid, one fibroid, and don't have any other fibroids in there, the recurrence rate will be less than someone having multiple small fibroids and most of them were not removed.
Yeah, I asked this question because I have a lot of women in my life who've gone through the surgery and they say, yeah, I probably will need a surgery in 5, 6 years because it'll come back. You know, this is common discourse in the community. So that's why I asked the question.
It's very important to know that, you know, having surgery is for a reason. So let's say you have multiple fibroids, okay? You need to get pregnant, and these fibroids are hindering your pregnancy, okay? The goal is to do a really good fibroid removal that will last you at least 5 to 6 years down the line, so you can get pregnant the number of times you want. And then after that, we will, revisit the fibroid issue. So that's the window I usually give my patients if these fibroids are hindering fertility. So our goal is to bridge you for 5 to 6 years without fibroid so that you can get the number of kids you need, and then we will deal with fibroids in a different way.
Have you seen women get pregnant and deliver their child healthily who also have fibroids, who never
Oh,
did the surgery?
many women.
So there are women who don't need the surgery, who have many fibroids and have successful pregnancies and
Of course,
successful healthy deliveries.
of course. And there are women that they had the surgery and they got pregnant after the surgery because these fibroids were hindering pregnancy. So preoperative evaluation is super important. That's what I'm saying. You just don't go blindly you have to deal it on a case by case basis, and you have to understand what the goal of your patient is, and that's the important thing.
I'd love to ask you about post-operative recovery, what that looks like. Also, how painful is the surgery? And then if someone is trying to conceive, how long do they have to wait after surgery? Yeah, just to get a general idea of what all that looks like if a woman does decide to go through surgery.
First, I would advise everybody not to have open surgery for fibroids. We have better ways these days of having minimally invasive surgery involving, small cameras and keyhole incisions. It could be laparoscopic or robotic surgery. I prefer robotic surgery because it's just simple and better, and it allows us to remove more fibroids quicker and with less blood loss. So the important thing in fibroid surgery, the most important thing is how fast you are, because time is bleeding. So the more time you take, the more the uterus is bleeding, the more you're going to lose blood. And with robotic surgery, it makes it as easy as open surgery, but with the benefits of having a minimally invasive surgery, basically faster recovery. So the recovery is about 10 days to 2 weeks. People can go back to work. And The only thing that lasts more is exercising. It takes up to 6 weeks for people to resume their exercising. Pain after surgery, usually they stay one night in the hospital, the next day they go home. Pain is pretty much controlled on oral medication. The way I tell my patients is you're gonna have intensified, the pain like feels like intensified period and like severe bloating. Okay, this is how the pain feels, and of course fatigue from anesthesia and having had surgery and all of the above. Um, but yeah, recovery is about 2 weeks, versus open surgery. It might take you up to 4 weeks for recovery, and you will stay 2 nights in the hospital. It's pretty traumatic having open surgery.
And if a woman's trying to conceive, how long do they have to wait after surgery?
The weight will depend. The weight basically depends on giving enough time for the muscle of the uterus to heal, and we usually recommend 4 to 6 months before they try to conceive, so that the scar tissues of the uterus have uh, strengthened to the max, and then they can withhold the distension of the uterus that happens during pregnancy.
Have you ever seen a patient have their fibroids decrease or be completely eradicated naturally?
I have seen a lot of fibroids not grow, um, be stable for years, but I've never seen a fibroid just disappear.
There's some treatment, like natural treatment options that are being discussed in like the alternative health spaces, like castor oil packs on the pelvic area. Apparently, it shrinks fibroids. There's also an enzyme called serapeptase and natokinase that apparently can shrink protein growths in the body without affecting like muscles. And of course, you discussed vitamin D deficiency, and there's also a compound in matcha or green tea called EGCG that if you start dosing at a high dose without the caffeine, of course, that could naturally shrink a fibroid. Have you come across any of these treatments?
Yeah, I mean, the EGCG is based on basically having an antioxidant properties. Okay, and I'm sure all of these methods have a good prospect for the future. But the way we want this to happen is through evidence-based studies, okay, not on just personal experiences. And before I can recommend them to anybody, uh, that's what we need, all right? Having them, uh, you know, in good peer-reviewed studies, so we understand their effect, and we understand that their effect on fibroids is not just related to bias, and it actually works.
Have you seen that when a woman goes through menopause, that their fibroids shrink
Of course,
naturally? Okay.
of course, and this is one of the um, that's why I mentioned age is very important in when it comes to treating fibroids, because people that are close to menopause, we can just bridge them symptomatically until they hit menopause, and then menopause will take care of the rest, because menopause is estrogen deficiency, and having um, stopping the stimulation of fibroids from estrogen will cause them to shrink, and will cause them to many a times not cause any symptoms anymore.
I'd love to ask you what one of your most memorable or challenging cases with a patient was around fibroid treatment or surgery or just general kind of reproductive health.
Yeah. Actually, not long ago, 2, 3 days ago, we had a very interesting case. A lady came from the US actually, and she had this 25 centimeter fibroid that was really occupying the whole abdomen, not only the pelvis. So it was reaching up to her liver, just from the uterus. And this patient has been scared and freaked out about the treatment for fibroid, because really when you think about it, I mean, we're limited a lot with options, especially with big fibroids, I mean, you need surgery. Okay, but this is a huge fibroid. Where am I going to do the surgery? Who's going to be able to do that? And what kind of surgery? Because there's a lot of things out there. Okay, do I do an open surgery? Do I do minimally invasive? Am I a good candidate for minimally invasive? And then she starts like consulting with many physicians, and most of them just advise her to do an open surgery. And when you have a fibroid like this huge, if you want to do an open surgery, it's going to be a cut from here down to the pubic bone. So it's going to be a transverse cut. And if you want to do a vertical incision for this, it's going to be an incision from the umbilicus down all the way to the pubic bone. It's kind of pretty disfiguring for a 30-year-old lady, It's disfiguring, and also to recover from a vertical incision, it's pretty much painful, and I mean energy consuming and all of that. So after seeing a lot of other physicians, she came to me for a consult, and I mean, I was the first one to tell her, you know what, I don't agree with open surgery. We're going to do this robotically. And after giving her this option, she was super excited that at least somebody can give me what I really want and not big cuts. Okay. Yeah. I mean, of course, she was super scared. I mean, the whole preoperative period, which was 2 weeks by the time I saw her, and then we counseled her, and then she came back for pre-op, discussed all the options, discussed all the risks and benefits. She was super scared. So we went in for surgery. It was a successful robotic surgery. It was only 4 small incisions. And then the fibroid turned out to be 2.5 kilos. Just one
Whoa.
single fibroid. So she was living with a 2.5 kilo fibroid inside her belly for years, and with all the symptoms that come with it. Early satiety, she couldn't eat much because it was compressing her stomach. Pelvic pain, intercourse pain, pressure on the bladder. She used to pee 30 times a day. Pressure on the rectum, with all the feeling of having, rectal fullness all the time. So, I mean, you should see a reaction afterwards. The simple reaction after we're done with the surgery, really 2 hours after the surgery, okay, you should just see her reaction, how she was not in pain. She was so ecstatic and happy that all she could feel that her belly is empty. Like this feeling of having, not having anything in your belly, okay, fasting for a long time, this feeling of feeling light, in a 30-year-old lady, that makes a big change. And yeah, there are stories where really people are just scared because, I mean, you could end up in the wrong hands, or you can end up with a complicated surgery that can cause complications, all of the above. So usually women are scared when they have a case beyond the normal what we see on a daily basis. They're scared because they don't really know what the end result is going to be.
That sounds like an incredible case. I'm sure that woman's life was completely transformed. Her quality of life absolutely improved. I can imagine she must have felt a whole lot lighter to have an almost, 2.5 or 3 kilo fibroid or growth in the body. So that's a pretty significant and substantial situation. Before we close, I'd love to ask you, what's one piece of information or advice you wish women knew about their reproductive health?
So I'm going to focus more on pelvic pain. I hope women, I hope I can deliver as much awareness about pelvic pain as possible, so women are educated that pain is not normal. Pain that goes beyond taking a tablet of anti-inflammatory is not normal. You should not be incapacitated a week per month. You should not be having signs and symptoms of anemia every time you have a period. You should not be having difficulties when it comes to reproductive health. If you have any of those symptoms or problems, then better check it with somebody. And also, if you feel there's something wrong and your physician has dismissed you, do not give up, because you will always find somebody who can pinpoint the problem. So that's my advice to them. First, educate yourself about pain when it comes to reproductive health. Educate yourself about endometriosis. Educate yourself about fibroids. And I hope that we can spread more awareness about this.
And also taking too many NSAIDs or anti-inflammatory drugs. NSAIDs are, for people listening, non-steroidal anti-inflammatory drugs like ibuprofen. If we take this very often or too regularly, it can actually impact our gut health. So if we're taking strong doses of ibuprofen every month for years on end, that's also not an answer. So as Dr. Elias says, if you've got pelvic pain, don't give up. If someone dismisses you, find the right doctor for you. And also, just to reiterate some of the advice you shared during this interview, is find a doctor that's also a surgeon and also has an expertise in all three conditions, which is fibroids, endo, and adeno. And you also mentioned it's so important to have an MRI because that type of imaging will catch things that maybe an ultrasound might miss. Is there any other advice that you would offer women who are dealing with fibroids or pelvic pain just before, they're choosing their doctor or they're in their doctor's office?
Yeah, my biggest advice is choose someone who listens to you and who will give you a plan, because that's not a condition that will go away with simple medication. It's a lifetime condition. You need somebody who can give you a plan for the next 5 to 10 years. And this plan will depend on your age, if you have kids or you don't have them, if you're planning on having kids or not. So the plan for these conditions is more important than just a one-time visit. And the plan will involve many things, including, egg freezing or embryo freezing, including medical therapy, including follow-up plans, including surgical plans. So many of that will be involved. So the plan is more important than just a one-time visit.
Dr. Elias, thank you so much. Before we close, where can people find you if they'd like to learn more about the work that you do or if they'd like to book a consultation with you?
So people can have more awareness about endometriosis and fibroids on our website and on our Instagram page at Dr. Elias Abi Khalil. I work at CMC Dubai. This is where I am all the time. Anyone who would like a consultation, we do online consultations and we do in-person consultations at CMC Dubai, which is Clemenceau Medical Center.
And I will link everything below. Thank you so much for your time and for sharing all this valuable information with us.
Thank you. It was such a pleasure.
Thank you for listening. Please share with family and friends that you feel could benefit from this episode, and make sure to hit that subscribe button and leave a rating and review to support the show. Check out the links below for more information about my guests and where to find them. And make sure you're following me on Instagram at wholesome_practice to learn more about what I do. I appreciate you being here and see you on the next one. This podcast is for educational purposes only and should never replace the advice of your doctor or physician. Always consult a medical professional before making any changes or adding anything new to your diet, lifestyle, or medication protocol.